Hello everyone, I welcome you to another lecture by me, Veena Velmurugan. Today we are going to see about vitamins and minerals, about the excess, about the deficiencies, about the clinical manifestations. So this video is going to be a little bit long, so I will give you timestamps. You can scroll and see whichever part you want to learn about right now. Without further delay, let's jump on to the topic. So first let's learn about the vitamin A. In vitamin A, we are going to see about the retinoic acid receptor. So that is the vitamin A receptor. So this is our DNA. So the DNA has the promoter region. A few base pairs downstream to the DNA, the mRNA polymerase will start producing the mRNA from the DNA. So if you want to know in more detail, I have another video about all this. So where I will give you the link and then you can check it from here. The promoter region will be having the retinoic acid response elements. So these are the retinoic acid response elements. So these are the specific DNA sequences which can attach the retinoic acid receptor with the promoter regions. This is the retinoic acid receptor. So once the retinoic acid sits on the retinoic acid receptor, it will get activated and the polymerase RNA polymerase 2 will start transcription from this DNA into the mRNA and thereby the proteins will be produced. Okay, so how does this happen? So this happens by this conformational change. So this is our DNA and this is the promoter region. So the promoter region, we have the retinoic acid response elements which are attached to the promoter region, to which the retinoic acid receptor is attached. So normally the retinoic acid receptor will be attached to co-repressors. They are the co-repressors to it. Now, when the retinoic acid binds to this retinoic acid receptor in this way, then it facilitates the recruitment of the RNA polymerase 2. But initially, it will remove these co-repressors. After this retinoic acid receptor is bound to this retinoic acid, the co-repressors are released and a co-activator complexes will be attached to it. So this will possess histone acetyltransferase activity and thereby it will recruit the necessary machinery and the transcription of the target genes is increased. This is how the vitamin A receptor acts. How is this vitamin A used in acne treatment? We use topical retinoin, which is the first line treatment for acne because it will shut off the sebum production. And oral retinoin, which is the most effective for acne, but since oral retinoin will become a high dose vitamin A, that is teratogenic. Sometimes we get a doubt like previously we saw the mechanism of action of retinoic acid, that is a vitamin A, that is the retinoin. So a retinoin, when it is applied over the skin as used for acne, so can it enter the cell's nucleus? Yes, of course. Retinoin is lipophilic, allowing it to pass through the cell and enter the cytoplasm. Inside the cell, the retinoin can directly bind to the retinoic acid receptor and then it can produce its effects. This is what you should know. Topical retinoin is not teratogenic, but it can result in a desquamation, peeling and photosensitivity. But the oral retinoin is teratogenic and it can result in cleft lip and cleft palate. This is an important point which is asked in USMLE. Let's learn about vitamin A deficiency and vitamin A excess. Vitamin A is required for our night vision, skin and immune function. So when vitamin A is deficient, it will result in nyctalopia. Skin is abnormal, so it will result in squamous metaplasia and immunodeficiency. The deficiency is generally rare because vitamin A is fat soluble and it is also stored in high amounts in the liver in eto cells. But deficiency can be seen or it can be caused by malabsorptive disorders such as cystic fibrosis, celiac disease or Crohn's disease. Excess of vitamin A will cause cerebral edema with pseudotumor cerebri. That is, there will be a raised intracranial pressure, there will be papillary edema, there will be confusion. And vitamin A can also result in teratogenicity. Sometimes Vitamin A excess can result in hepatotoxicity and also dyslipidemia. What is ursine or bear liver? Bear liver is a known cause of toxicity. So it was in olden days people used to eat bear liver which had a very high concentration of vitamin A, and therefore those who consume bear liver will have a vitamin A toxicity. So that is the ursine liver or bear liver toxicity. So now let's learn about our next vitamin, that is a vitamin B1 or the thiamine. So vitamin B1 thiamine, this is mostly theory. It is used for three important dehydrogenase reactions. So first important dehydrogenase reaction is that where the pyruvate will get converted to acetyl CoA. So I can give you a link to the glycolysis where I will be explaining in detail to it, and also about the gluconeogenesis chapter. And alpha ketoglutarate dehydrogenase, while alpha ketoglutarate will be converted to succinyl CoA in the TCA cycle. Again, I will give you a link on TCA cycle, and there we have the branched chain keto acid dehydrogenase enzyme deficiency, which will result in maple syrup urine disease, where there will be an inability to metabolize leucine, isoleucine as well as valine. Again, vitamin B1 is important in trans ketolase enzymes, which is the one which is produced in HMP shunt. So, in vitamin B1 deficiency, what is the most important features? We need to remember CoA, or sometimes people also suggest GOA. So, GOA or COA. So, C is mostly confabulation, O is ophthalmoplegia, and A for ataxia. Confabulation is like they will be having an amnesia, retrograde amnesia. They will be forgetting a small part of their what had already happened, and so they will be coming up with the stories which are not true, but then to fill up the gap in the memory, they will be coming up with the stories. So you can either remember it as a C for confabulation or G for global amnesia. That can also be another keyword. So, and therefore in any emergency setting, so in any unconscious patient, B1 will be given along with the glucose so as to prevent this thiamine deficiency. Apart from CoA, we also have beriberi, which is another important symptom of thiamine deficiency, which is the wet beriberi and the dry beriberi. Dry beriberi is a neuropathy and wet beriberi is the cardiomyopathy, which is caused because of thiamine deficiency. The next vitamin is our vitamin B2, riboflavin. The riboflavin is important in mostly as a cofactor in FAD and FMN reaction. We have an important step in the TCA cycle where FADH2 is produced when succinate is getting converted to fumarate with the help of succinate dehydrogenase. So the FADH2 is produced and the cofactor is riboflavin. The deficiency of riboflavin, that is ariboflavinosis, where there is angular cheilitis, although it is a non-specific finding, ariboflavinosis presents as angular cheilitis. You can refer to my TCA cycle videos to have a clearer understanding of the TCA cycle. Niacin, that is the vitamin B3, is used for many reactions which involve NAD and NADH. So this is not only a fact, this can be tested, this knowledge can be tested in exams, like the question might give you a patient with B3 deficiency and then have you select adenine as the answer. That is nicotinamide adenine dinucleotide, isn't it? So that adenine as the answer. This is because B3 is part of the cofactor that contains adenine. So this is how this knowledge will be tested. And niacin can be helpful for cardiovascular effects such as increased HDL, by increasing our HDL, and by decreasing the VLDL, whereby we will be decreasing the triglyceride export by the liver. And another thing we need to know that niacin, the precursor for niacin is tryptophan. Tryptophan can form either niacin or it can form a serotonin. So heart nerve disease is the inability of the proximal convoluted tubule of the kidney to reabsorb the tryptophan. So therefore we will be losing tryptophan and result in niacin deficiency. And similarly, carcinoid syndrome will also consume tryptophan leading to niacin deficiency. This is because it will be consuming serotonin and therefore tryptophan will have to get converted to the serotonin which is lost in carcinoid syndrome, and less tryptophan will be available for a niacin formation. In this way, both heart nerve disease and carcinoid syndrome can result in niacin deficiency. The deficiency will result in three important Ds, that is dementia, dermatitis and diarrhea. It can also present as delirium. The biggest risk factor for delirium is the underlying dementia. Dermatitis will present with as either Casal's necklace or sometimes as hyperpigmentation of the forearms or blistering. Excess of niacin, even though niacin is essential for cardiovascular effects, excess of niacin can result in hyperinsulinemia such as insulin resistance and diabetes. Niacin can increase the uric acid levels by competing with the uric acid for excretion in the kidneys. So, niacin can result in hyperuricemia. Similarly, niacin will also cause cutaneous flushing, which are mediated by prostaglandin D2 and prostaglandin E2. So, how will this knowledge be tested? The question will give you a guy who has a big cardiovascular history and podagra, that is the gout of the big toe, and they will ask which agent is contraindicated. Niacin is contraindicated because niacin will cause hyperuricemia and therefore it will aggravate gout. In this way, we should know that niacin will result in it will cause uric acid competition, will compete with uric acid forming hyperuricemia and contraindicated in gout patients. And the flushing which is caused by niacin is due to prostaglandins and not histamine. Therefore, prostaglandin antagonists such as aspirin or NSAIDs can be used to prevent or stop the flushing. And therefore, the wrong answer will be histamine. Histamine will not be a cure to prevent the flushing which is caused by niacin. Either NSAIDs or aspirin has to be provided because the major mechanism of flushing is the excess of prostaglandin E2 and D2. The next vitamin is our vitamin B5, which is the pantothenic acid. So this vitamin is a precursor to coenzyme A, whereby vitamin B5 will help to transfer coenzyme A to pyruvate so that acetyl CoA is formed. When vitamin B5 or pantothenic acid is deficient, it can result in burning feet syndrome. Vitamin B6 is or the pyridoxine. This is the most clinically important vitamin because it is useful in three important reactions. One is the decarboxylase reaction where levodopa will get converted to dopamine by dopa decarboxylase with vitamin B6 and alanine aminotransferase where there is a transamination reactions. Pyruvate and glutamate can form alpha ketoglutarate plus alanine. So this is by ALT and vitamin B6 is the important cofactor for this reaction too. The most important is the succinyl CoA which will combine with glycine in the presence of ALA synthase and the cofactor B6 to form a delta ALA. In this way, vitamin B6 or pyridoxine is necessary. What about vitamin B7? That is the biotin. Biotin is also helpful in carboxylase reactions where whereby pyruvate carboxylase is the enzyme which will convert pyruvate to oxaloacetate. This is an important step in gluconeogenic pathway. I will give you a link to my gluconeogenic video whereby you can have a detailed look about the pyruvate carboxylase. The second important one is that acetyl CoA can convert it to malonyl CoA by acetyl CoA carboxylase. The third important carboxylase reaction is the propionyl CoA carboxylase, where propionyl CoA will get converted to methyl malonyl CoA. I will tell you in detail about this propionyl CoA carboxylase. When there is a fatty chain which is broken down, then the 2 carbon units will be released as acetyl CoA units. But in case of odd chain fatty acid, finally we will be having a 3 carbon unit that will be released as the propionyl CoA. This propionyl CoA will get converted to methyl malonyl CoA and that methyl malonyl CoA with the help of methyl malonyl CoA mutase will get converted to succinyl CoA in the TCA cycle using B12. I will help you understand this with the help of a diagram. So see, this is what the propionyl CoA is an intermediate in the odd chain fatty acid metabolism. So that propionyl CoA from fatty acid oxidation, we will be having odd chain fatty acid oxidation, we will be having propionyl CoA. With the help of propionyl CoA carboxylase and biotin that is B7 as a cofactor, we will be generating methyl malonyl CoA. Methyl malonyl CoA with the help of methyl malonyl CoA mutase will be forming a succinyl CoA. So for this succinyl CoA to form, for this methyl malonyl CoA mutase, which it will require vitamin B12 as the cofactor. For carboxylase, we have this B7, but that is a biotin. But for this, we need the B12. So this is important to understand the further deficiency about the cobalamin. And this biotin deficiency we can acquire biotin deficiency by eating raw egg whites. This is because of the avidin protein which is present in the egg white, which can bind with the biotin and result in biotin deficiency. Vitamin B9 is the folate. This folate can assume numerous forms, including tetrahydrofolate, 5-methyl tetrahydrofolate, and 5,10 methylene tetrahydrofolate. So this folate is very, very, very important, where DUMP or the uracil can form a thiamine when this methylene group is transferred to the uracil. So this B9 folate is the most important to transfer the methylene group. Uracil with 5,10 methylene tetrahydrofolate can form thiamine and tetrahydrofolate. Similarly, the homocysteine can get converted to methionine. I have a separate video about homocystinuria. I will give you the link. You can brush up your knowledge on homocysteine. Homocysteine can get converted to methionine by transferring a methyl group to homocysteine. So homocysteine plus 5-methyl tetrahydrofolate and B12 can form methionine with tetrahydrofolate. For both the reactions, we need folate, but in homocysteine reactions, we need in addition to B9 or the folate, we need B12 also. So this is very important. So folate is important in to form thiamine as well as methionine, but B12 as well as folate is important in methionine. So in case we have a folate deficiency, they will be presenting with megaloblastic anemia, where they will be having hypersegmented neutrophils. And they are, if the child is the mother was suffering from folic acid deficiency, the child can present with neural tube defects. What is the difference between folate versus cobalamin? Folate is essential for the remethylation of homocysteine to methionine. That's what we saw previously. So when there is a deficiency of folate or B9, it will result in a buildup of homocysteine because the conversion of homocysteine to methionine is impaired. But folate is not involved. So for this conversion of homocysteine to methionine, we need B9 as well as B12, which I am emphasizing again and again because it sometimes it confuses. But the folate is not involved in the metabolism of methyl malonyl CoA, where methyl malonyl CoA with the help of methyl malonyl CoA mutase can form succinyl CoA, which is an intermediate in the TCA cycle. For that, we need B12. Henceforth, so the B12 deficiency, in B12 deficiency, both the enzymes will be impaired. Methionine synthase will be impaired because B12 was not there, therefore methionine will not be produced. And similarly, methyl malonyl CoA mutase also cannot happen, and therefore succinyl CoA cannot form, and there will be excess of methyl malonyl CoA. The cobalamin deficiency, vitamin B12 deficiency will also result in a megaloblastic anemia and hypersegmented neutrophils similar to our folic acid deficiency. In addition to it, in B12 deficiency, we can have subacute combined degeneration where the 2 or more 3 tracts will be affected in this subacute combined degeneration. The most important cause of cobalamin is oral B12 is the veganism or vegetarian diet, which contains very less vitamin B12. In addition to it, parietal cell loss, where there will be deficiency caused by loss of parietal cells, like for example a pernicious anemia or gastric bypass or chronic gastritis, where the intrinsic factor will not be produced properly. So for the vitamin B12 to get absorbed. The vitamin B12, even though the intrinsic factor is produced by the stomach gastric cells, after getting attached to the intrinsic factor, the vitamin B12 can be absorbed only in the terminal ileum. So terminal ileal, even both, that is parietal cell loss as well as the terminal ileum resection or absorptive disorders affecting the terminal ileum such as Crohn's disease can result in a vitamin B12. So both of it can result in vitamin B12 deficiency. Coming on to so now we have finished our vitamin B complexes. We are now proceeding to our vitamin C, that is the ascorbic acid. Ascorbic acid, I have a lecture on collagen synthesis where I have taught about the cross-linking of the collagen fibers with each other. That is the hydroxylation of the proline and lysine residue. That is the important step even before cross-linking can happen. So for the hydroxylation of the proline and the lysine, we need vitamin C. And for absorption of the iron in the duodenum, vitamin C is very important. Vitamin C deficiency, quite obvious, it will result in scurvy, which are the bleeding comes. What is the role of kidney in calcium homeostasis? Now we are coming to our calcium. So kidney plays an important role in calcium. Calcium in the proximal convoluted tubules of the kidney, the 25-hydroxycholecalciferol will get converted to 1,25 dihydroxycholecalciferol, and that 1,20 via the 1-alpha hydroxylase. And that 1,25 dihydroxycholecalciferol will in the distal convoluted tubule will cause calcium reabsorption, and this is regulated by the parathyroid hormone. This is how in calcium the kidney plays an important role. How is vitamin D and calcium and 1,25 dihydroxycholecalciferol are all related? That's what we are going to see now. The synthesis of vitamin D will start in the stratum basale of the skin. The skin contains cholesterol. So when the skin is being exposed to the UVB radiation, then the 7-dehydrocholesterol can get converted by UVB radiation to cholecalciferol. This cholecalciferol will first go to the liver, where it will be hydroxylated to make 25-hydroxycholecalciferol. The 25-hydroxycholecalciferol, as we previously saw, will then move to the proximal convoluted tubule of the kidney, where it will be converted to 1,25 dihydroxycholecalciferol by 1-alpha hydroxylase. This 1,25 dihydroxycholecalciferol has two important roles. One is to absorb calcium from the distal convoluted tubule in the kidneys, and the other is to absorb calcium from the small bowel, as well as the phosphate absorption. In this way, 1,25 dihydroxycholecalciferol, which is the active form of vitamin D, helps to absorb calcium. But we do face with even with vitamin D deficiency and vitamin D excess. Vitamin D deficiency, obviously it will present as rickets in children and osteomalacia in adults. But hypervitaminosis, vitamin D excess, is due to granulomatous disease, which is almost always sarcoidosis in exams. Vitamin E. I want you to remember this picture for vitamin E, because vitamin E is a free radical scavenger where it will incorporate into the cell membrane and it will donate a hydrogen atom to free radicals, thereby neutralizing it. Vitamin E, along with free radical scavenger, it has one more important effect, that is the antiplatelet effects. It will reduce the platelet aggregation and it can cause bleeding, and because it reduces the platelet aggregation, and it can enhance the anticoagulant effects of drugs like aspirin and warfarin, because the main effect of aspirin and warfarin is it's a blood thinner, isn't it? So therefore vitamin E will, which is also reducing the platelet aggregation, will also act as a will enhance the effects. So in excessive doses, that is more than 400 international units per day, vitamin E can increase the risk of bleeding due to inhibition of platelet adhesion. We have a question over here, that is what is the effect of chemotherapeutic agents on and vitamin E? The chemotherapeutic agents, mainly doxorubicin and cyclophosphamide, has to stop the progression of cancer cells. They do that by generating the reactive oxygen species to damage the cancer cells. But when it is given along with vitamin E, which is a free radical scavenger, but whereas this, which acts by generating reactive oxygen species, their effects kind of contradict. So therefore they should not be combined together. Let's come on to the another important vitamin, that is the vitamin K. Vitamin K is a cofactor for gamma glutamyl carboxylase. What does gamma glutamyl carboxylase do? It will activate the clotting factors 2, 7, 9, 10. So therefore in vitamin K deficiency, the 2, 7, 9, 10 are not activated and the patient will present with bleeding disorders. So how will this knowledge be tested? Vitamin K is produced by the microbes which are present in the bowel. So this is how the question will present. Older patients who are on broad spectrum antibiotics, where the microbe which is present on the bowel is disrupted, then they will be presenting with umbilical bleeding from umbilical stump, or else with vitamin K deficiency, or just simply bleeding. So this is how the knowledge will be tested. Coming on to our next topic, that is the copper. So for in I if you want me, you can I will give you a link on of my collagen video. So whereby you can see about the lysyl oxidase. So collagen, when it is initially forming, it will form a hydroxylation with proline and lysine residues. So for that, vitamin C is important. But after once a part of collagen is formed, they will be cross-linking of there will be cross-linking of newly synthesized collagen. For that cross-linking to happen, we need lysyl oxidase. It is an essential cofactor. So for the lysyl oxidase, copper is an essential cofactor. We have two important diseases. One is Wilson's and the other is a Menkes. Wilson's is autosomal recessive, where there will be excess of copper. And the chromosome number 13 is the one which is a defective in Wilson's disease. This is because the inability to secrete copper into the bile. But Menkes is a disease where there will be inability to reabsorb copper in the duodenum, and this is an X-linked recessive disease. Let's learn more about iron. Iron is an important component in hemoglobin, and hereditary hemochromatosis, where excess is seen in hereditary excess of iron is seen in hereditary chromatosis. Again, similar to Wilson's, this is also an autosomal recessive disease, and the defect is in chromosome number 6, whereby it leads to increased duodenal absorption of iron. Generally, iron is regulated in the duodenum itself. If the body needs iron, it will absorb iron. If the body doesn't need iron, it will not absorb iron at the duodenum itself. That is how the iron mechanism of iron is regulated. In hereditary hemochromatosis, there is a defect in chromosome 6 which will result in increased duodenal reabsorption of iron. What is selenium and what is zinc? Selenium is an essential cofactor for glutathione peroxidase, which is an important enzyme in the body. And zinc is the one which is used in zinc finger motifs or zinc finger domains, which are part of some transcription factors. Let's come to another important topic, that is on calcium. So in hypocalcemia, there will generally be tingling or hyperreflexia. So generally calcium is necessary, but when the calcium is not there, there will be excitability. So this is how the question will be. 35-year-old female who presents with tonic-clonic seizures, again excitability of the nerves, tingling of hands and feet, again excitability, involuntary contraction of muscles of hands and hyperreflexia, excitability of the muscles and hyperreflexia happens. So all these points towards hypocalcemia. Let's see what are the causes for high calcium and low calcium. In high calcium, it is mainly because of sarcoidosis, where in sarcoidosis 1,25 dihydroxycholecalciferol is produced in excess. So therefore, that is the active form of vitamin D3. Therefore, more of calcium is being absorbed. And primary hyperthyroid parathyroidism also, there is excess of PTH, and therefore more calcium is reabsorbed. And low calcium are causes such as rickets, osteomalacia, and a secondary hyperparathyroidism, where even though the parathyroid produce excess of PTH, it cannot act on the kidney. It becomes resistant. The kidney is resistant. So this is another cause for low calcium levels. What about the sodium? Sodium can cause CNS dysfunction such as confusion, stupor, or coma. High sodium and low sodium causes are there. So high sodium are generally, there will be primary hyperaldosteronism, where for no reason the aldosterone is produced in excess. The second one is renal artery stenosis. In renal artery stenosis and dehydration, there will be the body will in renal artery stenosis, since there is not much blood to the kidneys, the body will assume that the kidney will assume that the entire body is fluid deficient, and therefore it will start reabsorbing lot of sodium, therefore withholding water along with it. Dehydration, there is really no, the body is dehydrated, there is not much of water, so therefore the high sodium is produced and it is resulting in dehydration. Along with it, diabetes insipidus also happens, also causes high sodium. Similarly, low sodium causes are the Addison's disease, which is an where there will be aldosterone, less of adrenal production, as well as psychogenic polydipsia and the SIADH. What about potassium? Potassium derangement will result mainly in cardiac dysfunction such as arrhythmia. That is this. High potassium causes are Addison's disease, renal failure with agents such as potassium sparing diuretics and digoxin, where we give potassium sparing diuretics, and therefore it will result in high potassium. Low potassium causes are primary hyperaldosteronism, which will result in excess of sodium absorption and excretion of potassium. So therefore it will result in low potassium. And renal artery stenosis, again it will result in an excess of sodium absorption and release of potassium. And Cushing's disease, where per se it will result in a so now let's finish this topic with the phosphate and the magnesium. So high phosphate, the most important cause of phosphate, excess of phosphate is hypoparathyroidism, where the parathormone which is released by the parathyroids will cause calcium absorption and phosphate excretion. But if the parathormone is not produced, then the calcium will not be absorbed and the phosphate will not be excreted. Therefore, the phosphate will stay within the body. So the most important reason for high phosphate is hypoparathyroidism, where the PTH is produced in less, or PTH deficiency will result in high phosphate. And a secondary hyperparathyroidism, where even though the PTH has been released, it cannot act. So therefore there will be excess of phosphate. Renal failure, where it cannot excrete the phosphate. Tumor lysis syndrome, where phosphate is released from the cell because of the lysis of the cell, which happens in tumor lysis syndrome. And the sarcoidosis, where there is excess of 1,25 dihydroxycholecalciferol which is produced, which will absorb both the calcium as well as phosphate from the small bowel. Low phosphate causes are the are exact opposite to these. So like primary hyperparathyroidism and rickets and osteomalacia, or else the refeeding syndrome, where all the phosphate enters into the cell. All these are the low phosphate causes. So let's finish this with our magnesium, the important topic, that is magnesium. Magnesium is very important because magnesium is mostly seen in alcoholism, where there is a decreased dietary intake. It will lead to hypokalemia and hypocalcemia. But even though they treat the patient with hypokalemia and hypocalcemia, I mean they treat the patient with calcium as well as potassium, they will be non-responsive to treatment, to supplementation, unless unless the magnesium levels are corrected. Thank you for listening all this while. I am happy that you have come to the end of the slide. I hope this is helpful to you. If you have any questions, you can write to me. I am more than happy to clear all your doubts. I have an announcement for you. I am starting my mentoring lessons for medical graduates and USMLE aspirants. If you like my videos and if you like the way I teach, you can sign up for my mentoring class. I can't wait to see you succeed. Thank you. Have a good day.